and we've had a lot of conversations at coffees that Lincoln Independent Business Association has, and she told me a lot about what she does, and I thought, wow, I would love to have her speak at one of my talks because she has a whole set of information. Come on in, good to see you, that I don't have. And so I'll let you just take off, Casey.
Yeah, perfect.
Okay.
Do I clip this on or hold it? What's the most effective?
You can clip it. Yeah.
There you go. Does that work?
Sort of.
I know this isn't a very
there you go.
Shirt.
Okay. There you go.
I don't like collared shirts, you guys. So quick introduction. Yes, my name is Dr. Casey Bogenreith. I'm a physical therapist. I'm from Nebraska. I got my degree in athletic training at the University of Texas. And then I got my doctorate of physical therapy at the Mayo Clinic. So I left Nebraska for 10 years, came back. I am now married. I have 2 kids. I worked in home health care for a decade. And I have worked in every level of, I guess, physical therapy. So I've worked in an ICU. I've worked in a hospital. I've worked in a rehab facility. I've worked in outpatient. I've worked in inpatient. I've worked in home health care. And now I own my own private practice. So I do mobile physical therapy and wellness. My specialty is aging adults. I am extremely passionate about injury prevention. So after years and years of seeing people get injured, being in people's homes, understanding risk factors, especially with what we call lifestyle diseases. So heart disease, diabetes, things that can sometimes be prevented. I realized that my true passion was identifying risk factors and trying to prevent people from having issues, in addition to resolving the issues that people have. So today, our presentation is called Gait Speed, the 6th vital sign. So if you've ever been to the doctor, which hopefully all of you have, oftentimes they take your vital signs, which is your blood pressure, your heart rate, your temperature, your respiratory rate. And when they take your vital signs, it's an indication. It's information about your well-being. Now, normally you just go in, they do all of that and you move on. But sometimes one of those factors is out of the range of what's considered normal. So for example, a normal heart rate at rest is 60 to 90 beats per minute. So if for some reason your resting heart rate is 120, that's an indicator to them, maybe we need to run some extra tests. Maybe we need to ask a few more questions. Same thing with all of the other vital signs that they take. Now there's 5 primary vital signs, but according to research, the unofficial 6th vital sign is actually your gait speed, which is how fast you walk. And I can almost guarantee that none of your physicians have ever actually measured that particular sign. So in terms of vital signs, just reminders, resting heart rate, normal heart rate, 60 to 90 beats per minute. Blood pressure is 120 over 80. I'm not used to holding my notes. I usually have them on screen. Respiratory rate is 12 to 20 breaths per minute at rest. Now, the tricky thing about respiratory rate is it's very hard to measure on yourself because the second you try to think about how many times you're breathing, you will artificially alter how fast or how slow you're breathing. So generally, your provider is actually doing that while they're having a conversation with you, which is pretty cool. We're very sneaky like that. Oxygen saturation, which is that little doodad they put on your finger with the little light inside. We want that to be around 99%. Now, for some people, because of pulmonary or cardiorespiratory issues, that might be lower. So normal might be, again, a little bit more of a range. And then temperature, which we know to be 98.1, which oddly enough, that is an oral temperature. So depending on where your temperature is being taken, that might vary by about a degree. So there's oral, there's ear, there's under the armpit. Now there's the forehead thermometer. So 98.1 is still textbook what normal temperature is. But oddly enough, normal temperature is actually a little bit lower because of the mechanisms that we measure it. So gait speed. For data, for research, we actually use meters per second because the United States is the only country that wants to use standards. So everywhere else, most of our research is always going to be in metric. So the definition of speed is literally the speed at which you walk average. So not like, oh my gosh, I'm running to the bathroom. Not, oh, I'm just like having a normal walk. The kind of average pace that you would self-select to move. And again, we use meters per second. And this is important because just like your other vital signs, it's measuring a data point. It's giving us information about your health. So I am a big fan of research studies. Dr. Firnhaber and I talk about that all the time, that evidence-based medicine is extremely important because the scientists are the ones who are researching and using very large groups of people to give us this data. So it's not like a single case study, one person, this was the outcome. It's thousands of people were tested under very specific parameters to identify information. So one of my favorite studies for gait speed in particular, there were over 34,000 participants in this study that were measured. So this is a cohort study, meaning they used lots of different research studies. And they can, again, now with AI, they can do this way faster, but they read all the studies, they find all the variables, and they determine the outcome of those studies in basically a generalized result. So of over 34,000 people, age 65 and older, 59.6% were women and 79.8% were men. So again, men do walk a little bit faster than women. So that's where this average might be slightly skewed. Men walk faster than women.
The one before that, the percentages.
Oh.
That didn't make sense.
Oh, because some people drop out of the study.
Oh.
And there's multiple studies. So it's not like a singular study. But the basis is that we had more men who were measured than women. But the average gait speed was 0.92 meters per second. Okay. So we will come back to that number, but 0.92.
That's everybody?
Yep. Average on everybody in the culmination of multiple different research studies.
It's a little less than a meter per second.
Exactly. Okay. Yep. And what they found was survival, meaning how long you live, essentially, was determined by your gait speed. And the statistically significant interval was 0.1 meters per second. So what that means is the slower you walk, you don't live as long. The faster you walk, you live longer. That's what this study determined. And why gait speed predicts survival is because the speed at which you walk is based on multiple organ systems. Okay, so you check your heart rate, that's your heart and a little bit of your lungs. You check your breath rate, that's your lungs and a little bit of your heart. You check your temperature. Well, that could mean anything, usually like infection or like a systemic illness. But gait speed measures multiple organ systems. It also measures your movement control and biomechanics, your energy level. It can measure your support, the structural musculoskeletal support you have in your body. And it also integrates your nervous system of how well you can know where your body is in space.
Sounds a lot like chiropractic.
I know, gosh. So their conclusion was that gait speed is the sixth vital sign. And this was actually, this culmination of studies, this single research paper is only one of many that have determined this same outcome of how gait speed can be utilized as a tool to recognize our health status. So it's not like, oh, you walk slow, you're going to die. That's not how it is, but it's a tool to indicate that something might be awry with the general function of your body.
Can I ask about how many people in that study have died? So that
I mean, they all die because everybody dies, but no. These people were living participants, but
so how did they extrapolate the death if they're still living?
So there's follow-up studies. So it determined, I think this one had, let's see.
That's a great question.
Follow-up for 6 to 21 years. So there's multiple studies for a long, very period of time. So some of these very involved research papers, some of them are 6 months. Some of them are 6 weeks. Some of them are multiple years. So in fact, in some cases, there's studies on pediatrics where they'll follow up for that person's lifetime. And we're lucky enough in modern medicine that we have these abilities to follow people for long periods of time because modern medicine isn't really that modern anymore. We've been doing it for a long time.
Yeah, I have a daughter that when she was in kindergarten, we were in Washington State, the University of Washington, did some testing with her, and then they were following. She's in her 40s now, and they still do that with her.
Exactly.
And
Exactly. So they do this a lot on twin studies. They do it on like pediatric illnesses. They do it on really some chronic illnesses. So again, not atypical for a research study to be following up decades later. And now we have the technology for them to do that. People can remotely submit information. They can, there's a lot more ability to electronically contact people. Now, again, there's attrition. Not everyone follows up. All research studies are voluntary. Sometimes you get paid, but not always. So that's where that comes from. And we'll go over a lot more in detail of those gait speed numbers. So the conclusion, gait speed could be considered a simple and accessible summary indicator of vitality because it integrates known and unrecognized disturbances in multiple organ systems, many of which affect survival. In addition, decreasing mobility may induce a vicious cycle of reduced physical activity and deconditioning that has a direct effect on health and survival. So that paragraph of conclusion again indicates that slow gait speed doesn't mean you're not going to survive, but gait speed is representative of your overall health, and decreased gait speed and thus decreased health does predict your longevity. So brief overview, if you're not familiar with organ systems, we've got lots of different organ systems. Now we categorize organ systems to better understand how the body works because all of the organ systems essentially integrate together. So we can't really leave any organ system out. And again, that's why gait speed is integrating. So gentle reminder, your organ systems are your lymphatic system, which is how you maintain fluid in your body. Your endocrine system, which is hormones. Your GI system or your digestive system, which is literally anything that goes in your mouth and comes out the other end. Your reproductive system, which is self-explanatory, slightly different for men and women. Your immune system, so your white blood cells and how you fight off infection. Your urinary system, also called your excretory system. Nervous system, musculoskeletal system, respiratory, circulatory, and integumentary, which is just a fancy word to say your skin, which a lot of people forget that your skin itself is an organ. It doesn't just look pretty. It actually prevents things from getting out or from getting in, prevents things from getting out, intentionally removes things from getting out, like sweat, holds in our blood, and helps with the structure of our body. So here are the statistical norms that you might be a little bit more interested in hearing. So there are lots of different research studies. There's a lot of different information. So the numbers will vary slightly depending on which resource you are using for statistical norms. Same thing with some of the data that I use. I like to use government websites where the information is readily available to everyone. So for example, the American Heart Association has recommendations on like how much cardiovascular activity you should do. That's readily available, readily accepted. But again, these norms are always being looked into, researched, and updated, but I try to do what's the most accessible. So for men aged 50 to 59, 1.49 meters per second is the average gait speed. Now you'll notice that as we go up each decade, the gait speed gets slower, and this is just because we are aging. That is normal. It is not pathologic, but as we all know, as we age, our bodies begin to break down. So 50-59, 1.49 meters per second. Men age 60 to 69, 1.3 meters per second. Ages 70 to 79, 1.26 meters per second. And aged 80 to 89, 0.97 meters per second. So each decade, you can expect about 0.5 to 1 meters per second decrease in your gait speed. For women, 50 to 59 is 1.31 meters per second. 60 to 69 is 1.24 meters per second. 70 to 79 is 1.13 meters per second. And 80 to 89 is 0.94 meters per second. So men walk a little bit faster than women, and the only reason is because their legs are a little bit longer. And they tend to carry a little bit more muscle mass at baseline versus women. So
And we know Curio's heavy first.
I know, right? All right.
I've got a question about that.
Yes.
So when they're measuring this, like, it's almost, to me, it's almost like breathing, Casey. Like, if you're trying to measure your breathing, you're going to
Exactly.
like change it. And it seemed like you somebody's measuring my gait speed, I'd probably want to walk faster than normal. How do they
People
do
that? Yep. So as part of this presentation, sometimes I will actually do a gait speed assessment for people. Now, in studies, they usually use a 20-meter path. And what happens is 5 meters is a warm-up. So it's to account for acceleration. It's to account for artificial speed. 10 meters is the measurement space. And then there's a 5-minute deceleration. Now, normally for participants, we try to hide where that start and end time is so that they're just like, here, walk this line. But the idea is that people should self-select to their normal pace. But yes, sometimes people will artificially speed up. Now, in these studies, I did not do an in-depth look into how they did the measurement. That's the standard measurement, is we literally just lay it out, use a stopwatch, or now they have censored timers for when your foot passes a certain spot. But sometimes what they'll do is maybe use an entire track and average the pace. It just depends on the study. But when I do it clinically, I measure out 20 meters. I have an acceleration zone, a deceleration zone, and I just use a stopwatch. 5, 10, 5. Mm-hmm. Yep. Another really easy way to assess your gait speed is get on a treadmill and walk and figure out which pace of walking feels the most comfortable for you. Because the other thing about gait speed is some people can't walk an entire mile, but we can still assess their gait speed. So these slower gait speeds, these people aren't walking 10 miles at a time. We might only be able to measure a short spot. And again, some people can't get on a treadmill, but if someone's wanting to kind of self-understand what their normal pace is, you might be able to kind of click up and click down to find where your personal preferenced pace is, if that makes sense. So more research studies, because that's what I like to do. They've actually statistically determined what gait speed allows you to be a community ambulator versus someone who might be homebound. So community ambulator, someone who walks out in the community. So everybody who's physically here today, you had no problem getting into a car. You had no problem walking into a building. You may have taken the curb and not had an issue. Versus someone who's homebound. Now, we use that term clinically to mean someone who has difficulty mentally or physically leaving the home. These are people who have difficulty getting in and out of a chair. These people might not even sleep in a bed. They might be using a recliner. They might have an assistive device like a walker or cane. They might not be able to negotiate a curb step or even get in and out of a car independently. So based on gait speed, if your gait speed is less than 0.4 meters per second, it is likely that you stay at home unless you have assistance to leave. Again, this is statistical, it's not guaranteed, but people who walk slower probably have some other physical or mental handicaps that prevent them from readily walking long distances safely. Between 0.4 and 0.8 meters per second, again, limited community ambulation. So if you're below 0.8 meters per second, it is possible that walking is unsafe for you unless you have some sort of assistance, either from a device or another person. 0.8 to 1.2, that's the threshold for community ambulation. These are the people who, again, are walking, getting in and out of cars, leaving their home more or less readily. Now, 1.2 meters per second is kind of the big threshold to be aware of, because that is the pace that crosswalk timers are set. So if you're an architectural engineer and you live in a big city and you're trying to get past a crosswalk, if you are walking slower than 1.2 meters per second, you will not get through the intersection fast enough. So I say that pace. I think it's important for people to know. Again, most of us take our cars and park right in front. But if you are walking around downtown or anywhere, it's just something nice to be aware of. And again, a lot of people don't know what their gait speed is. They just know, like, I don't leave home. Or they just know I can't get across the crosswalk. Or they just know I might need some help to get up the stairs. So in terms of the statistics, those thresholds, that again, these studies have determined that if you are less than 1 meter per second, it is a strong predictor of falls in what they consider the elderly, which generally is researched as age 65 and older. 0.8 meters or less of your gait speed is statistically predictive of frailty. Now, again, we use that word in different places, but clinically, if you are medically frail, if that is a diagnosis in your medical chart, there's actually a clinical criteria that defines frailty. It often has something to do with your bone density, your muscle mass, your risk of falling, and other clinical factors such as comorbidities. So less than 0.8 meters per second means you probably want some medical intervention to address not just your gait speed, but your overall health, because walking that slow indicates that those organ systems, there is some sort of concern. And then again, 1 meters per second or less is statistically demonstrated to indicate risk of falls. So let's talk. Go ahead.
I was going to say, I was going to bring somebody to this to listen that her meters are less than 1.8. I mean, her walking speed was less than 0.8.
Oh, someone's measured it for her.
Well, no, I could just.
You just know.
Yes.
Yes, that's okay. Yes.
So I thought, well, it's going to take too long to get her to hear this, but I think it's going to be over her head, so I'll just have to get it. But I thought, now, are you going to show how there's some way to
Yes.
increase that?
Yes, yes. All the scary stuff's at the beginning of the presentation, then I'll tell you all the things you can do at the end. Yep. So the last thing is, as a physical therapist, and a lot of what I do is identifying fall risk factors. So while gait speed has all of these predictive factors, and it demonstrates, again, unfortunately, some sort of issue with the body and how we're functioning, there are other fall risk factors that I think are extremely important to bring up. So the first, and again, these are statistical fall risk factors. This list of fall risk factors is an assessment that we use. Actually, if you've ever had home health care, every single home health care provider is required by the Medicare, essentially, to perform this particular assessment. So statistically, if you have 4 or more of the following risk factors, you are at risk for falls, statistically. Now, I'm going to preface by a fall is an unintentional descent to a lower surface. A fall is an unintentional descent to a lower surface. That does not mean you got hurt. I am standing here. This chair is lower than me. If I do this, that is a fall. If I'm sitting and I sit on accident, that is a fall. So for our statistical measures, when a doctor asks, have you fallen? They're not asking, did you get hurt? They're asking, did you unintentionally descend to a lower surface? So the first risk factor, unfortunately, this one is not modifiable. If you are 65 or older, you are at a statistically increased risk of falls. Next, 3 or more diagnoses. These are medical diagnoses on your chart that your physician has prescribed. And this can be literally anything. It doesn't have to do directly with falls. If you have asthma, if you have arthritis, if you have allergies, those count as comorbidities, not just congestive heart failure or diabetes or kidney disease or the more serious diagnoses that you could have. The next is prior history of falls within the last 3 months. So this particular assessment is intended to be repeated relatively regularly because your risk of falls can change based on so many different factors. Next, incontinence. Any incontinence. So there are multiple different kinds of incontinence. There's functional incontinence, meaning I just didn't make it to the bathroom fast enough, which is usually an issue with you. Your physical body couldn't get you there fast enough, or there's an issue with your pelvic health or your bladder control. There's also stress incontinence. I sneezed, I coughed, I whatever, and a little bit of urine came out. And then, of course, there's some other more like pathologic types of incontinences, but those are the ones that we're normally dealing with. And then nocturia, so having to get up to go to the bathroom in the middle of the night, that is considered incontinence. Next, visual impairment, any type of visual impairment. Now, in our aging populations, often we're looking at glaucoma, macular degeneration, but visual impairment can also mean you wear glasses and you were too lazy to put your glasses on when you went to the bathroom. Visual impairment. Impaired functional mobility could be anything, literally anything. So my back is sore. I wear orthotics and I didn't put them on. My elbow's flaring up. You're missing a limb. You can't feel your limbs, any type of impaired mobility. And again, that can vary. So the test is intended to be repeated. Next are environmental hazards. Again, this is broad. This is why I treat people in their homes. This is why I go to people's offices, is because environmental hazards could be this rug is not adhered down and I can slip on it. Environmental hazards could be I tip on a chair that's too light. Environmental hazards can be your cat or dog underneath your body. Next, polypharmacy. That's just a fancy word for you take more than one prescription medications. For the purpose of this particular survey, it's 4 or more prescription medications. Next, pain affecting level of function. Again, pain is subjective. So for some people, a 1 out of 10 pain is debilitating and they're not getting out of bed. Pain is affecting their level of function. Same thing. Gosh, my shoulder's really bothering me. I'm going to wear a button-up shirt instead. That is pain affecting your level of function because you are choosing to modify what you are wearing. And lastly, cognitive impairment. Now, this one's kind of tricky because cognitive impairment has a lot of breadth. So if we think about cognitive impairment, maybe we think about someone who has Down syndrome. Maybe we think about someone who has Alzheimer's or serious dementia, but early onset dementia or forgetfulness, or perhaps fogginess from a medication, perhaps being clouded after a surgery. Those are all cognitive deficits that could affect your fall risk. So of those 10 items, if 4 or more are present for you, you are at a statistically increased risk of falling. Additional complicating factors. So in addition to the survey that has so much data, again, thousands and thousands and thousands of people are taking that survey. They're always getting new data to determine what is putting you at a fall risk factors. Footwear. So you could slip on your shoelace. If you wear orthotics and you didn't wear them to go to the bathroom, if your orthotics are 20 years old, if your shoes are 20 years old, at some point footwear can affect your balance. Bracing orthotics, I already mentioned. So some people have a drop foot. Some people have a knee brace. Some people have hip brace. Some people have different assistive devices physically on their person. Well, for the short distance that you had to go, if you did not put on that device, it could affect your risk. Same thing with assistive devices. If you use a walker or cane, I've got people who maybe they use a walker, maybe they use a cane, but the 10 feet to the bathroom, they're like, oh, I don't need it. And guess where people always fall? In the middle of the night, when they didn't turn the lights on, they didn't have their glasses, and they didn't use their walker. Unlevel surfaces. So this can be inside or outside. This can be stairs, this can be curbs, this can be rugs, this can be surface changes between carpet and hard floor. And especially for people with Parkinson's or early onset, visual changes going through thresholds really affects how your body is seeing space. Structural abnormalities. So if you're missing a toe, if you're missing an arm, which changes your center of balance. If you have any type of sensation loss, which oftentimes we're seeing in peripheral neuropathy for someone who has diabetes who can't feel their toes or their foot, that will affect your balance. And lastly, gait mechanics. So just the quality of which you walk, which for people who are new users of devices like canes and walkers, when they were given that device, so often the doctor's like, here, use a walker, here, use a cane, but you were never taught how to use that properly. And now you're wanting to use your arms to stabilize your gait, but you never strengthen your arms sufficiently to hold that much of your body weight. So again, if we teach people and we strengthen people's upper bodies to support the use of the device, maybe they won't end up walking like this using compensatory muscles. So what now? That all sounds super scary, right? So the reason that I'm so passionate about fall prevention, gait speed, and early intervention when we discover risk factors is so many of these issues are preventable. Or we can at least prepare your body to accommodate for when something bad could happen if you are at risk for falls. So I typically kind of divide this into 2 sections. If you have 4 of those risk factors and you are a fall risk, the interventions are a little bit additional. But ultimately, the interventions are comparable, just one's a little more urgent than the other. So if you guys don't mind sharing, who is a fall risk factor? Did you guys kind of make a mental note of those factors? Don't be embarrassed if you are. Okay. So we'll go over kind of my personal recommendations. Now, again, as you know, I'm a physical therapist, I'm an athletic trainer, I'm a health coach, and I'm a yoga instructor. Those are my credentials. I do like to read studies. I collaborate with different medical professionals all of the time. So these recommendations, again, are my own. They are based on my own personal research. They are based on evidence-based studies that I have been aware of. That's not to say this is the end-all be-all of options, but it's pretty comprehensive in my opinion. So the first thing is annual balance assessments. Just like you go to the dentist every year, right? You go to the optometrist every year. You go get your blood work done every year. Maybe you go to the chiropractor regularly. You should get a physical assessment every year. Now, that could be specifically for balance, or it might just be function. Can you get up your stairs safely? Can you get on and off the floor safely? Can you reach to the floor to maybe feed your pet? Can you reach to the top of your cupboard? Can you lift the heaviest item that you would need to, like a gallon of milk or a bag of dog food? Or a cat litter. Exactly. So it's not because I'm concerned that every single person is going to have an issue. But just like you go to the dentist, they clean your teeth, see you next year, or see you in 6 or 9 months, depending on what your insurance is or what you want to pay. So same thing for balance. You come, you assess your balance, we get your baseline data, see you next year. And then when you come back next year, we have the data. We have your gait speed. We have your fall risk. We have the other assessment measures. Again, evidence-based numbers. And we see, are you getting better? Are you getting worse? Do we need to do PT this year or do we not? Do you need to start doing X, Y, and Z? Do we need to collaborate with other healthcare professionals to keep you as low of a risk as possible? Now, I can't change your age, but some of those other modifiable factors, we can increase your home safety. Maybe we need a railing on your stairs. That's an easy fix. Maybe we need to set your dog food in a different place. That's an easy fix. Second recommendation, 3 times a week of resistance training. And this is especially important for women because we have less muscle mass. So it's not that we are a higher risk of falling. It's that when we fall, the resultant is worse. And the statistic that nobody wants to hear is after a hip fracture, the 2-year mortality rate is staggering.
Can I ask you a question on that?
Yes.
I've wondered about that. Why exactly is that, Casey?
It's a pathologic fracture. So for women, after age 40, on average, you will lose, I believe, it's a percentage. I don't remember what the percentage is every decade. You will lose a percentage of your muscle and bone mass.
But why is it a 2-year death sentence?
That's the statistics. I don't know why 2 years. That's just how it is. It's because your body takes so much time to recover. So in someone who's completely healthy, a bone fracture takes 4 to 6 weeks. Okay, so if you've ever heard it's better to fracture it than to have a tendon or a ligament issue, bones have so much blood flow. Bones are hardy. And if you're healthy and your system's functioning, you stabilize the bone and in 4 to 6 weeks, it's healed. But the problem is that for women and for men, we're all losing bone and muscle unless we are actively resisting that degeneration. But again, because women start with a lower density, we're smaller people, we have more to lose. And because of our hormonal changes through menopause, we are less likely to maintain muscle and bone. But you fracture a hip, right? Now, technically, fractures of bones is trauma, right? So I broke my hand when I was 13 and it's because I was doing gymnastics, right? Someone, little kids, it's usually the monkey bars or whatever. For adults, a fall, this is not that far. Okay. Have you ever seen a little kid learning how to walk? They're durable, right? Your pelvis is one of the thickest bones in your body. So when your thickest bone has its core gone, essentially. So normally brittle bones, it's because the inside of your bones are hollow now. basically. That's kind of how that brittle bone happens, is that the bone building stopped, and what happens is the bones get hollow. So if your thickest bone breaks, that's an intense strain on your immune system. The amount of rerouting of blood, the amount of calories that are burned every day, the amount of time to remodel that bone. And again, your hip is your densest bone. This is the deepest part. This is the deepest joint in your body that is so well adhered down by fascia and muscles and tendon that when that breaks, the surgery to repair it is unbelievably invasive. And if you've ever heard of surgery, like orthopedic surgery, they call it glorified carpentry, because that's what it is. There are mallets, there are hammers, there is drilling. Thank God there's anesthesia. It is very aggressive. So if you take the year that it would take to recover and the possibility that that person's immune system can't handle that, again, invasive of a surgery, that's probably approximately where that 2 years comes in.
That makes a lot of
Is
sense.
that if your bones are that degenerated, your body can't handle that type of procedure, essentially. But again, the bone fracture itself, you're probably not doing so great anyway.
But your body's got to get used to those pieces that are not going to
Hardware. Yep.
Yeah, the antibodies.
Yep. You don't want to reject the material.
Yeah, for 20 years I've worked to use bioidentical hormones, different types of things that doctors suggested for building up, bone density.
Mhm.
And it wasn't until I was researching it that I have now found that this one product called Algae Cow has made a huge difference with another product. It's an illness. There's 2 products you take. It's a strontium citrate with that. And that has made my osteoporosis go to osteopenia. And I'm expecting it to be gone because my bone density is just changing. That's after 20 years. I didn't take the prescriptions that doctors wanted me to, and after years of finding out what's happening to people that have, I'm glad I didn't. But I am recommending people look into algaecow.com.
Yeah. There's so many interventions. There's so much research, pardon me. There's so much research.
As far as products,
And
there's
women's health,
one that I found that you
women's health is new. Literally. Women's health past maybe 40 years, women's health has been separated from men's health. Interventions for women versus men are different. Our body weight is different. Our bodies work different. Our hormones are different. Our cycles are different. Everything is different. So again, for women who, again, are more prone to bone mineral loss, it is still a new realm of understanding how to treat hormone changes through menopause, how to treat our risk factors versus men. So how did you was that self-research that you figured it out?
But the algae cow has been around for 20 years. And I learned about it 3 years ago. So they already have thousands of people that have had fabulous results from it.
Yeah, I love it.
Men and women.
I love it.
I would definitely, in fact, my doctor, when I told him about it and he saw the results, and then he said he and the secretary were asking, what are you doing to make this reverse? And I told him, so he's suggesting people try it.
Yeah, I think that's great. Yeah, again, research, the definition of stupidity is repeating the same thing over and over. And the most intelligent people are willing to accept, okay, this is what I thought was right. I learned something new and I'm willing to modify. I'm willing to adjust.
That's what I've been doing for years.
So that's wonderful.
Every year, finding out what my density is. It's been going up or down.
And at that data point every year is exactly the idea, is to have those
now it's been
points.
going up and going up.
I love that. So yep, the other statistically significant option is strength training, which again, I don't know how much it will literally reverse.
For 10 years, and they say, oh, maybe that was a factor. Well, I'm sure that was a factor. It's important to get that, that, and then that's kind of your bones and muscle working like that. But it is the product that makes the difference.
Love it. Yep. Any other questions?
I have a question.
Yeah.
Is there a gait speed that they would say that you're on a longevity path if you can do this gait speed?
Not that I'm super aware of, but again, based on the gait speed deterioration per decade, the higher your gait speed, similar to like the higher your bone mineral density before you start to age, I would assume it would be somewhat correlated to that. But that would also be based on continued regular activity.
Right.
So unfortunately, the data actually is 25. So calcium in pediatrics and kids. So like when I was a kid, like the Got Milk campaign was a big thing. Now, not everyone's into dairy products, but you still need calcium. So however it is you're getting your calcium, that maxes out, they've determined around age 25. So similar to certain motor coordinations and physical tasks, is actually optimal to start as a kid, but the data shows you can build muscle at any age. So even when they do studies in people who are in their 90s, when they do regular strength training, because there's a principle called SAID, S-A-I-D, specific adaptation to imposed demands. Your muscles are attached to your bones. So when your muscles are engaging and when your muscles are getting bigger, that forces your bones to get stronger to accommodate the forces of the muscles pulling on them. So while again, I don't know the DEXA data, but if you strength train to make your muscles bigger, by default, the osteophytes in your bones have to grow the bones to support those muscles. So that's where the strength training comes in as something you can proactively do to foster your bone density. And again, the current recommendation is 3 times per week. And again, strength training is literally like lift something that feels really heavy. It could be dog food. It could be weights. It could be anything, but physically lifting. So my next strategy for combating or improving gait speed is cardiovascular activity. So this is where that statistic for the American Heart Association comes in, is 150 minutes of walking per week. That divides into 30 minutes per day. Now, super annoying, but true fact is walking does not build muscle. Now, if you are completely sedentary, yes, you will gain muscle walking, but it is not the same as actual resistance training. So while all of the different components of fitness overlap, similar to our organ systems, the effectiveness of each should be performed independently. So if we think about the different components of fitness, we think about strength, we think about cardiovascular fitness or endurance, we think about flexibility or range of motion, we think about balance and coordination. And while we can integrate these activities into one, if I'm deadlifting and I'm trying to deadlift my body weight, well, I'm not going to go run 10 miles and then be able to max out on my deadlift. Same thing, I'm not going to deadlift my body weight a bunch of times and then try to go run and expect to be at my top speed. So while cardiovascular health is very important, especially for your gait speed, because you need to be able to tolerate a semblance of walking, it is not as effective for physical improvement of the muscle size and the bone density. But again, all connected, both equivalently important in improving gait speed. My next recommendation is 2 times a week of some sort of mind-body practice. Now, I'm biased because I'm a yoga instructor, but that mind-body practice can be anything. It could be Tai Chi, it could be prayer, it could be singing, whatever it is that you choose. It could be reading, it could be silent study. Our mental health is just as important as our physical health. And there's more and more data talking about meditation, sleep quality, downtime, stress suppression, having time to down-regulate your nervous system. So I say 2 times a week. Again, ideally it's more journaling. That's, I guess, another one. I say 2 times a week. That's like at minimum, but ideally we're doing those practices a little bit more. Fun fact for you, Tai Chi and yoga are the only statistically proven interventions other than physical therapy to decrease fall risk. Next, medical screens. So I talk about the annual balance assessment or the annual functional assessment every year. Well, all of your other providers need to be seen. So you still need to go to the optometrist every year, the dentist every year, your physician every year, get your lab work every year, just to make sure as preventative. So if you're a perfectly healthy person, I still think you should go to those providers at least once a year. They'll check to make sure you're okay, and then you can be off into the sunset until next year. Lastly, for prevention is social support. So exercising is way more fun with friends. Number one, it's more fun. Number two, it's someone to hold you accountable. So sometimes, ultimately, you have autonomy. You are the only one in charge of you, but having a buddy to hold you accountable, to be there to help, especially if you're not currently doing regular activity, that's really important. So fall risk intervention, if you are a fall risk, everything I just said, super important, but should be done a little bit sooner. So, if you do have a slow gait speed, the sooner that you could start intervention, the better. Additionally, a home safety evaluation, I think, is really important. So railings, rugs, surface changes, clutter, where your pet's food is, all sorts of things can decrease your safety. A bed that's not stable enough and you slip off, you have silk sheets and it's hard to get in and out of bed. There's so many different factors that can be modified to prevent you from getting injured. Next, assistive devices. So some people really look down on walkers and canes. In the right usage, they could be absolutely life-changing for people. So I've got plenty of people who they don't use it at home, but they use it when they're out and about because there's more obstacles, there's more surface changes, there's more unknowns versus your house that you know where everything is and you walk every day. Now, one of the easiest ways to tell if someone needs an assistive device is if they walk around their house like this. And you know it, you've seen it. If someone is needing external support, it makes sense to just have that support directly under your body. And again, as I mentioned earlier, anybody who is prescribed an assistive device, that should be correlated with an upper body strengthening program, at least for 4 weeks, to develop the appropriate muscles to weight bear. Because if you go from nothing to using a walker, you are essentially walking on your hands. And people are not utilizing the correct muscles because you've never used those muscles ever in your life. So, very important. Next, physician coordination and specialist coordination. So, Dr. Firnhaber and I, we've talked about this. People need a healthcare team. And as we get older, our bodies start to degenerate. More bad things happen. We need more people on our team. And it is so pivotal that those people are able to communicate with one another. Now, unfortunately, our current healthcare system doesn't do a really good job of opening those outlets because people are too busy. I max see maybe 5 clients a day. Another physical therapist in an outpatient clinic is probably seeing 35 patients per day. It's not that they don't want to give each person individualized, collaborative, custom care. They physically don't have time. So it requires us to be our own case manager of our healthcare. It's not great. It's hard. You might need to delegate some of that to a friend or a family member or someone like me who helps to manage cases of complex medical conditions. But if you don't already, you should have a list of all of your medications, and that should go with you to every medical appointment. You should have a list of all of your medical diagnoses, and that should go with you to every appointment. Because if your cardiologist changes a medication and 2 weeks later you go to your primary, they don't know that that medication was added. If you go and get a treatment one place, they might not have access to it at another place if they don't have an integrated electronic medical record. Next, personalized programming. We've talked about so many different risk factors, all of these different organ systems, anything that could go wrong with your body. Well, because each person is a fall risk for a different reason, because each person's gait speed is different, that requires personalized programming. So if you have numb feet, your gait speed prescription, your exercise prescription is not going to be the same as someone who has dyskinesia. That's not going to be the same as someone who has a vision issue. I'm not going to prescribe the same recommendations for person A and person B because your status is completely different. And your providers should not be doing that either. Nobody is a textbook prescription for anything. And if you ask any physician, any medical professional, if they say Is this what you learn in school? The answer is no. It's not. We apply what we learned to the case in front of us. The more tools we have in our toolbox, the better we are. I went way over time, you guys. I'm so sorry. All right, last thing. 2 things that also will help with, again, the organ function and your gait speed is nutrition and regular lifestyle choices. So again, I'm biased. I am a health coach. This is something that I teach people how to do. But what you eat matters. What you put in your body affects your function. And how you live your daily life affects your gait speed. If you are completely sedentary all the time, you are not going to walk as fast as someone who walks 2 miles every day. So those are the important integrating factors to consider. So the biggest thing is that knowledge is power, and the conversation starts now. And I'll end with my slogan: invest in wellness so you don't have to pay for it.
Boy, I can agree with that more. I could not agree with that. That's very good. Yeah.
So questions. Sorry, guys, I went